Good evening. Thank you all for joining us. Got a lot of people coming in, so we're going to get started here in a little bit. I'm going to send a quick poll to all of our attendees. This is anonymous. Would love for you to complete this as you are waiting for Dr. Dapash to get started. Good evening. We've got a lot of people joining the call. Thank you so much for being here. We'll get started in just a few moments. We have started a poll, if you don't mind. This is anonymous. A poll for you to complete just a few questions related to bowel control. Good evening, everyone. We'll get started in just a few moments. We still have a lot of people joining the call. Everything will be anonymous. Everyone is muted. And we do have a bowel questionnaire that has popped up. If you don't mind completing that for us, that would be great. And Dr. Dapash will get started in just a few moments. Okay, I think we're going to get started. Thank you all for joining us this evening. As you're coming in, lines have been muted. We will have a question and answer session at the end. Everything will be anonymous, so feel free to think through questions as Dr. Dapash is presenting. But do want to do a quick introduction for everyone. My name is Ashley Revis, and I work for Medtronic. And tonight I have the absolute pleasure of welcoming you all and introducing our fantastic speaker, Dr. Thaddeus Dapash. Dr. Dapash is a board certified, fellowship trained gastroenterologist with Carolina Digestive Health Associates, who's experienced, he's excellent and compassionate about his patient care. Dr. Dapash offers a full range of gastroenterology and hepatology services. He specializes in the management of inflammatory bowel disease, chronic liver diseases, esophageal and stomach disorders, colorectal cancer prevention, He has a particular interest in the treatment and management of fecal incontinence, which he's looking forward to discussing in detail tonight. Again, we're going to reserve time at the end for questions, so please use that Q&A box at the bottom of your screen. And there will also be a poll at the end of the session as well, so we can ensure that we follow up with you all and get you on the road to fecal continence, which would be great. So without further ado, Dr. Dapash, I will hand it over to you.
Can you guys hear? Can you hear me? All right. Good evening, everybody. Thank you for joining us this evening for this presentation. This topic has become near and dear to my heart since I started practicing after I encountered some patients dealing with some of these conditions that we'll talk about and how it negatively affected their lives. During that time, there were not a lot of options available, good options or effective options, until we discovered some of the therapies that we'll talk about today that did completely change and enhance their quality of life. Thank you for that great introduction, by the way. Actually appreciate it. All right, now we'll talk about fecal incontinence. It's one of those topics that I think has been really hard for patients to broach or to know where to seek help. A few quick statistics that, was shocking to me when I first discovered it was it affects up to 54% of it affects way more patients, but only 54% of patients have ever discussed it with their doctor. Now, some of the concerns patients have when this starts happening, number one, it is isolating. They don't know if it's happening to anybody else. They wonder, will I ever gain control? Can I possibly go on a date? Can I attend outdoor celebrations, get a job? Worst of all, they're afraid to leave the house and they feel that they're a hostage to the bathroom. And overall, it's just embarrassing. Now, this is statistics I wanted to mention that was a little bit shocking to me that it affects 1 out of 12 adults. That's 21 million adults in the US alone. Now, first thing to know is that you're not alone. This affects both women and men of all ages. And more importantly, it's not a normal physiologic change of aging. I've met patients who thought this was a natural aging process, and there were not a lot of options. Fortunately, that cannot be further from the truth. Now, living with FI or fecal incontinence can cause a lot of serious problems. It is embarrassing. It can lead to social isolation, which can worsen or cause depression, and it negatively affects their quality of life. Especially some of the patients that I met that love to socialize are involved in the community and they have to withdraw because of these symptoms. Now, what is expected and what is not expected? Bowel incontinence is not an inevitable part of aging. Now, if any of the following sound familiar, this is a perfect presentation for you. If you're finding yourself planning activities around the bathroom, you have involuntary loss in control of your stool. You have a bowel movement every time you go to urinate. You have stained underpants, and you find yourself using pads or protective garments. If so, your body's trying to tell you something. Now, how does this all work? How do you get bowel control? A brief summary of it is that there's a bowel-brain communication that is essential for your bowel control. If there's a communication breakdown, that can cause incontinence and bowel control problems. Typically, the digestive system pushes food throughout your intestines, and when it reaches the rectum, there's a stimulus that is triggered that gets transmitted to the brain, and then the brain allows for the relaxation of the anal sphincter for you to have a bowel movement. If that chain is interrupted, then you can have incontinence. There is really good news about this. There are many treatment options that can get you back to the quality of life that you desire. Now, there are conservative treatments. Not all therapies are appropriate for everybody, and we'll highlight some of those here. There are conservative treatment options and also advanced therapies. All right, some of the conservative treatment options can include simply some dietary modifications, whether that's incorporating fiber to bulk up your stool, decreasing fiber. There are physical therapy options. Kegel exercises are probably some of the more common ones to strengthen the pelvic floor and the anal sphincter. Then there's bowel training with physical therapy called biofeedback therapy. And there's certain medications that can help augment that sphincter function or help provide support. Some of these might be appropriate for you. Now, when those fail, or if they're not effective, fortunately, there are some advanced therapies that you can consider that we can talk about to see if they're appropriate for you. Some of them, surgical options, which we'll discuss a little bit, are probably what I would consider last resort. And I'll talk about why in a few minutes. And then there are minimally invasive treatment options. It's important to understand the trade-offs before you decide. Now, the surgical options, most of these aim to focus on physically repairing the anal sphincter muscles or open a large intestine out through the abdominal wall. Some of the post-anal repair, sphincteroplasties, and colostomy, for me, are a last resort. That's when all other measures have failed and there's really no options and we cannot control the symptoms. Fortunately, I've not had patients that we had to resort to one of these surgical options. The more desired and I think best treatment for me personally, the best treatment options out there is the minimally invasive one. Medtronic does have a bowel control therapy delivered by InterStim. And all this is, it's just a gentle nerve stimulation that targets the communication pathway that we discussed earlier and helps restore the brain bowel connection and function. It's clinically proven to stop or greatly reduce bowel accidents, significantly improves your quality of life. It's a testable therapy that is safe, it's minimally invasive, and it's been used since 2011. There are recharge-free and rechargeable device options that let you and your doctor choose the best fit for your lifestyle. Now, take back control. I think that is important. When you hear how heartbreaking it is for some of these patients that their whole quality of life from socializing, being involved in family events, and them losing control of their life because of these symptoms, it makes you understand how powerful this therapy can be for most people. There have been over 400,000 people worldwide that have had this therapy. The simple test starts at your doctor's office or an outpatient center. For us at Carolina Digestive, the trials are done at an outpatient center with sedation, so it's comfortable and it's just a very controlled setting. There's a small battery and wire that are used during the procedure. There are leads attached to external device that you wear discreetly. You can go about your regular activities for up to 14 days. We typically do 7 days because that's enough sample size to see if it's an effective treatment option for you. You record your daily symptoms, and then we talk about it to see if it will be effective for you. All right, proven results. 89% of people using Medtronic bowel control therapy experience long-term success. That is significant quality of life improvement from their lifestyle, ability to cope, the embarrassment component that we talked about, and depression. It's safe and effective and has been used since 2011. Now, the most common adverse events experienced can be pain from the implant, new pain, the lead migration infection, device problems, or adverse changes to your bowel avoiding function, undesirable stimulation or sensation. If any of these happen, then we can always talk about it. Fortunately, this has not happened yet. All right, InterStim therapy. Is it right for you? So you may be a good candidate for the Medtronic bowel control therapy delivered by InterStim if you have significant and chronic fecal incontinence symptoms. You've tried lifestyle changes, oral medications, behavior modifications without any good results. These treatments haven't given you the relief you want, then we should talk or talk to one of the GIs that specializes in this. Now, some of the more common questions or concerns, given that many patients can have other health conditions, is this MRI compatible, or is it safe once you get this device to undergo an MRI? The short answer is yes. MRI systems are designed to streamline MRI scans. It's only sacral neuromodulation system with this technology. No impedance checks required prior to MRI scans. Scans allowed, even if patients have had out of range impedance. MRI mode is easy to activate or deactivate on a smart programmer. All Medtronic InterStim systems and SureScan technology have the same MRI conditions. 20 years of MRI research, 1.2 million scanning scenarios, and 10 million simulated patient scans. Now, briefly, one of the most recent patients that we had, I actually have the log here, came in, had been having F5 for a lot of years. It was lowering her quality of life. Um, she was always having to go to the bathroom at work. And fortunately, her OB doctor, who gets credit, encouraged her to come in and talk to us. And once she did not realize that this was a problem that affected a lot of people, and there were really good treatment options. She was one of those patients who, after discussing her symptoms, we thought this would be a good option for her. So she underwent the trial and she kept a log. And this log illustrates how effective and life-changing this treatment option was for her. The log that I have here, she was having, 3 to 4 bowel movements a day, urgency, one daily accident. She was soiling herself. And at the conclusion of that 7-day period during the trial, all those symptoms had resolved. There was an 83% reduction in bowel movements, 100% decrease in urgency, and 100% decrease in accidents. That's that's the most recent success stories. Several years ago, we also did sacral neuromodulation. There was 2 patients primarily I remember who were negatively affected. They were kind of like beacons in the community. They underwent the sacral neuromodulation and the same success story. I mean, when you get to see how much it can change their life and how isolated they felt, um, it just gives you hope that, hey, if other patients are dealing with this, or if you're personally dealing with this, there are a lot of very good options. But the first step is, for us to sit down, have a conversation, hear your symptoms, and go over your history, and then we can talk about all the treatment options. This might not be right for you. There could be other effective treatments like the dietary modifications or medications that we talked about. But if this is an effective treatment for you, it is something that I'll be excited to share with you, and we can walk through the journey together. Now, if at the conclusion of this presentation, if it's something you would want to discuss, there's a phone number here that you would call, and we would get you in and we can talk. There's 4 other partners of the practice that also specialize with this that we can also get you to, but I encourage you to feel comfortable to come in and just have a discussion with us. Thank you for your time, everybody.
Thank you, Dr. Dapash. We've had a lot of great questions coming in, so want to go through a few of these with the group. I'm sure a lot of people have some of the same questions. So um, first question is this the same as the inability to control urine?
It's short answer is no, there's similar processes involved, but the urine would honestly require an evaluation from a urologist. There is some connection. The patients are able to capture both, but we usually was focus on the fecal incontinence part first ourselves.
And thankfully, though, if you have both, there are a third of patients that have fecal incontinence and overactive bladder, and this type of therapy can treat both at the same time, which is
Absolutely.
beneficial. Um, I have had my colon removed, colonoscopy. Will this program apply to me?
If if you have an anastomosis where you're connected, where you have bowel movements to the rectum, then yes, possibly, yeah. But if you have a colostomy, like a bag on the outside, then no. But if you were reconnected, then yes.
Very good. What is the cost of this treatment? Is it covered by Medicare?
Yeah, it is covered by Medicare. Cost, I think actually maybe can discuss more, but it is covered. I have not had a
Mhm.
patient that it has not been covered. And that's why the trials and keeping records when we go through the process is very important. If you demonstrate to the insurance there is a need and it's effective, I have not had any issues.
Right. Um, okay. Um, what medications are used to treat FI?
Yeah, great question. So there's a few medications. Um, the two primarily we use are help to augment that sphincter function. Lomotil is one, and like amitriptyline or TCA that has what we call anticholinergic effects can be a possibility. That's one of the medications that we typically would try. But with that, also sometimes there's medications either we increase fiber or we try to change the stool consistency depending on what your underlying problem is to make sure that medication's effect is optimized.
Very good. How uncomfortable is the test or the procedure, and can I go back to work after the test?
Um, so the procedure, so if we do it under sedation, um, there's no discomfort at all. We provide numbing medication at the site and your sleep when we apply the numbing medication. So there's no discomfort. If we use sedation, then we do not recommend you can go back to work the same day. There are patients that we have used it on that are not sedated. We just numb up that area and they can go back to work. But if it's not sedated, the discomfort is minimal.
Um, my problem is when I have a bowel movement, it doesn't all come out and is leaves a mess when I'm wiping.
Mhm. Yeah,
Will this
absolutely.
help?
Possibly. Yeah. So typically, if when I hear situations like that, then we have to really look at that pelvic floor first, stool habits and patterns, and then we review like your obstetric history, surgical history to make sure there's not other factors contributing to that. But the short answer is yes, this could potentially be helpful for you.
Yes. A lot of great questions coming in. Um, my stool is formed, but I have many per day. What would be the first step?
If you have a lot of form stools and you have a lot per day, then it will be something to decrease the amount of bowel movements you have, whether it's to increase fiber could be an option, and Lomotil could be a good option for that. And they're like an anti-diarrheal, even at a very low dose. But those are the two typical options. And the other thing is we probably would have to look at your diet. Um, how many times a day you're eating and things like that that can help us try to like decrease the frequency.
Mhm. Um, we've had several questions with regards to actual diarrhea.
Mhm.
Um, and kind of trying to get through these. With diarrhea versus, can you explain the difference between just diarrhea, which can sometimes, come from either diet or medications, versus incontinence, fecal incontinence?
Yeah. So diarrhea, when I hear diarrhea, is usually the consistency or frequency of your stool habits, right? Whether it's like liquid or very soft, and you have it multiple episodes for either per day. Incontinence is just the involuntary control. You cannot control it, whether it's like an urge incontinence or passive incontinence, where you feel the urge to go, but no matter what you do, you cannot hold it, it's coming out. Or you're having accidents at night. That's usually the incontinence part, where there's involuntary control of it, versus the diarrhea, where you're just going either multiple times or the consistency is just really loose or watery.
Okay, thank you. We've had a few questions with regard to bladder cancer, colorectal cancer, and then FI started post treatment, post radiation. If you could speak to that.
Yeah, that's usually one of the three main questions I ask that can lead to FI is your surgical history, obstetric history, and radiation. There are also other like neuromuscular conditions like Parkinson's and scleroderma that can cause it, but that's where we start. And yes, those typically can lead to FI.
Mhm. Yeah, that tends to be a common one for sure. Um, okay. When I have the test, are there any limitations during that time frame?
No, no limitations. I mean, you can go about your normal activities because the device is very discreet. There's no discomfort at all. So I don't anticipate any limitations to your daily activities.
Mhm. Okay. I have MS. Can this still help? Um, we've got a few that have had some things like that, MS or um, LAR syndrome. I think we kind of covered some of that though. But if you want to speak to that, Dr. Dapash.
Yeah, it can because the sacral neuromodulation, the good thing about it is, and what I like about it, it's not like a surgery. There's not like a recovery time. And all it does is just provides a gentle stimulation to one of the afferent pathways up to your brain to help the brain provide that stimulus or control that it once did. So people with MS, Parkinson's, some of those, neuromuscular conditions, yeah, this is a really great therapy for them because it targets the underlying problem.
What if, how does excessive gas fit into this treatment?
Excessive gas, that's usually honestly more diet. And unless you're having like anal incontinence, which is like involuntary passing gas, this probably will not be the first go-to for you. Will be dietary modifications, primarily through the FODMAP diet and looking at the foods that can be contributing to gas. Or if you have underlying enzyme deficiency that we also work up at our practice. But this will not be the first go-to if gas is the major problem.
We've had several questions about diet, and I think early in your presentation you mentioned obviously starting with conservative measures. Let's see if there is something from a diet perspective that's contributing.
Yes.
Um, so if you want to touch on that just one more time, so we have had several questions about that.
Yeah, so depending on the stool form, so we know, rectum kind of stands for straight, and we know that the sphincter cannot hold liquid very well. All right. There's some people that have overflow where, they're so constipated, there's like, seepage of stool around that fecalith, we call it. When it hits the rectum, that they cannot control the liquid from coming out. Part of the process, if that's your problem, would be to increase dietary fiber, whether we're supplementing with like a Metamucil or having you increase dietary fiber is one option. There are some options, same scenario, that we might actually have to decrease the fiber to loosen the stool and even sometimes add an antidiarrheal to help them regain that continence. So I usually do start with dietary modifications, looking at medications before we jump to some of the like, in advanced therapies.
Um, I have bloating issues for days, and then I can't have a bowel movement on my own. My doctor put me on a prescription. Will this help me more than a prescription?
I think dietary changes will help more than a prescription at first. And then after normalizing the bloating, if you're still having some of the incontinence or involuntary control issues, then yes, this will be. But with that patient specifically, we would start with their medication list, diet to try to figure out why they're bloated in the first place.
Very good. So we've got a few questions with regards to urgency, maybe not to the point of leaking, but what would first be helpful with regard to urge, so they're not running to the restroom.
Yeah. So like I talked about, when you realize how, your sphincter is meant to kind of differentiate between stool and gas. So you know when it's appropriate either to have a bowel movement or to expel gas. When you have liquid, that's very challenging to the sphincter because it's not meant to hold that very well. So if you have an urgent incontinence, I typically do ask about your stool habits, stool patterns, and whether it's like bulking up stool that if we have to do that. But if you after changing diet or addressing the underlying bowel issue, if you're still having incontinence or involuntary control, then yeah, this would be a great therapy for you. Some of this, and we meet a lot of patients that have the same issues. And that's why I think it's important to at least start with a conversation, right? Could be 15, 20-minute conversation, and a lot can be figured out in that period of time. There's a lot more people that, whether it's this therapy or other medications, could be really effective for them. Um, but it would start kind of looking deeper into their history to know what the best treatment option for them would be.
Very good. Um, could you provide a little bit of detail about the implant? So if the test is successful, and you go on, where does that battery sit?
Yeah. So we usually have you, there's some great colleagues we work with, luckily here in the Charlotte area, that we refer you to have a more detailed discussion. But the implant usually sits underneath the skin, like in the lower back. That's like a common area. Um, and it's like very discreet. Nobody will know that you have that device there. But we usually pass you on to one of the other colleagues, and they're phenomenal that we work with.
Correct. Okay. We have a lot of very specific questions,
Yeah,
like specific to patients,
yeah,
scenarios. So some of these would definitely be beneficial for patients to come in to make an appointment with the provider to come in because a lot of it is going over your specific medications.
yeah.
So no, Dr. Dapash and his partners would absolutely love the opportunity to talk to you about your specific scenarios, medication lists, that sort of thing. Um, okay. Here's one. Last year I had my hemorrhoids banded. Now I'm having frequent bowel movements. Could that be related? Would this be something that would help with those frequent bowel movements?
Yes, yeah. It can, any augmentation or change in that anal canal right before the sphincter can lead to some of these conditions. And yes, this could be a good treatment option for you.
Okay. We do have some questions with regard to conservative options. Your preferences on Miralax versus Metamucil, things like that.
Yeah. Metamucil, the soluble fiber part, I think it's a little bit more effective, especially for some of this IBS, and it's like, psyllium husk is a natural fiber. So if I had to pick between the two, I usually try Metamucil. Yeah, Metamucil first, unless it causes a lot of bloating, which it can for some patients, but there's a, a lot of patients that are on it without any symptoms. But Metamucil usually my first go-to.
And this is another just kind of conservative behavioral question
Yeah.
with regards to drinking coffee and other diuretic types of drinks. Noticing more incontinence with coffee, diet sodas, artificial sweeteners, things like that. Is that going to cause any fecal incontinence?
It can if it alters your stool pattern, right? We know some of these sugars, whether they're artificial sugars or like what we call an osmotic load, can really make the stool consistency very thin, and that can lead to the incontinence. Because the thinner the stool, the thinner the liquid, the harder your sphincter, the harder the time your sphincter has in control in it. And there are a lot of patients where it's an artificial sweetener or like what we call an osmotic load, or whether they're a diabetic that pulls a lot of water into the stool, causes diarrhea. Once we change that, then their stool consistency improves and their incontinence episodes also improve. Yeah, but they actually absolutely can contribute. Not black coffee by itself though, but if there's a sweetener, then yeah, I think it could.
Very good. And one additional treatment, excuse me, additional treatment, additional question. Um, do you or does anyone in your group see pediatrics and teens?
We do see teens. We do not see pediatrics. No, yeah, but teens we can see, especially like 16, 17. Yeah, we can see some of the pediatric patients. It is more case by case scenario. Um,
Okay. Um, and again, I think um, this is a good question too. So it's with regard to the implant, um, and questions related to infection at the incision site,
Yeah.
post implant.
You know, all surgical procedures, especially if there's an incision made, there are risk of infection, but most of the protocols that go into these procedures are help to minimize that. Yes, can it happen? Possibly. Is it probable it's going to happen? No. That's not like a common expectation at all. If one does occur, there are many ways to treat it and get it addressed.
Very good. And then any potential side effects to the actual treatment.
Besides like inject like the site where the leads are placed, maybe irritation there, you know, side effects of the sedation. Those can happen, but very rare for those to happen. I mean, it's a yeah, it's a very safe procedure. We don't anticipate or expect adverse outcomes, but if they do, they can be easily taken care of.
Wonderful. Um, okay. I think that's about it. And again, I think we've talked through the we're still getting some questions related to kind of diarrhea versus constipation. Does this help with constipation?
No, no. I mean, this is more for the control. It does not help with constipation, but we have plenty of treatment options for constipation. Like no one should really be suffering constipation these days. Um, but no, this procedure in itself will not, but there are plenty of other treatment options for constipation.
Correct. It's more of the incontinence, the urgency, the frequency.
Right, the accidents. Yeah, yeah.
Okay. And then there's some other really great, very, very specific to the patient questions.
Yeah.
Um, so those would definitely, as mentioned, those would definitely be wonderful questions to call into the office to be able to just review your history, your medication list, things of that nature. Some of this is related to certain foods that might be irritants, things like that to the bowels. Um, and then some very specific questions related to some other medical history. So, again, I would highly recommend everyone to call the office and to schedule an appointment. Again, whether you see Dr. Dapash or some of the other providers in their group, they're all fabulous. But they have a team ready to take these calls tomorrow. The number is here on this last slide. So feel free to give their team a call because these are all wonderful, wonderful questions. And we want to make sure everything gets addressed. So Dr. Dapash, any final words from you?
Yeah, absolutely. Do not suffer needlessly, right? There's no extra credit for suffering. I was, joke around with patients about that. Um, some of these patients suffer for years, and when they come in, whether it's the constipation, the diarrhea, the FI, and they're like, I could have seen somebody and had this addressed years before. So please come in, talk to me. We have great partners that I would send my family to because they're all excellent. Come in, let's have a conversation. Let's figure this out. Let's get you control back of your life and get you feeling, great and doing the things you want to do in life.
All right. Well, thank you, Dr. Dapash, and thank you everyone for joining. We had a lot of people on this call, so it just means there's a lot of people suffering with this, and there are certainly a lot of tremendous options for you. So, as he said, you don't get extra credit for suffering. We definitely want to be able to help you. So, without taking up too much of your time this evening, I want to say thank you all, and again, feel free to call Dr. Dapash's team. They are ready for you and ready to help. Hope you all have a great evening, and we will talk to you soon.
Thank you, everybody. Good night.